The American Brain Tumor Association is pleased to welcome you back to our webinar series. Our webinar today will discuss what happens at a brain tumor board and how can you benefit from this process. My name is Sue Ward. I'm the Director of National Volunteer Programs here at the American Brain Tumor Association, and I'm delighted to introduce our speaker today, Christopher McPherson, MD. Dr. Christopher McPherson is a neurosurgeon at the University of Cincinnati Brain Tumor Center and a member of the Mayfield Clinic in Cincinnati. He is also currently the director of the Division of Surgical Neuro-Oncology for the Department of Neurosurgery at the University of Cincinnati College of Medicine and associate professor in the Department of Neurosurgery at the University of Cincinnati College of Medicine. He is a member of the National Executive Committee for the Tumor Section of the AANS-CNS. Thank you for joining us, Dr. McPherson. You may now begin your presentation.
Okay, thank you, Sue. Well, as she said, today we are going to talk about tumor board, and I think this is a topic that a lot of people, a lot of you have probably heard about. But I think a lot of patients don't necessarily understand or get a good idea of what really goes on at a tumor board. So today what I'm going to go through is just some of the basics of what really is a tumor board and how do we do that. And then I'm going to show you some video presentations of some tumor board cases that we've set up so that you can actually see how tumor board works. So what is tumor board? Well, I think everybody has their own kind of mental picture of what a tumor board is like. I found on a website, kevinmd.com, this patient, Catherine O'Brien, who felt like tumor board was sort of like being in a courtroom. And she wrote this statement where she said, a tumor board is like the Justice League of Oncology, only instead of Superman, Batman, Wonder Woman, the Flash, and the Green Lantern, you get a bunch of medical, surgical, and radiation oncologists. It's a closed meeting. Cancer patients generally aren't invited to provide testimony or point out the accused. Ma'am, do you see the cells accused of breaking and entering your lymph system and attacking your vertebral bodies? Yes, I do. There they are, right on that slide. Last year, my oncologist presented my case to the tumor board. I envisioned Gregory Peck in To Kill a Mockingbird with doctors at tables on either side of a large courtroom, each passionately arguing for some treatment plan. So I wanted to share that quote. I think that's a really good quote from Catherine, and obviously she's a very imaginative patient. But I think that everybody has sort of a different mental picture of what tumor board is. So really, what is tumor board? Well, the bottom line is it's a meeting of specialists. And there are many different kinds of tumor boards. Each center has their own tumor boards. There are tumor boards for brain tumors. There are also tumor boards for breast cancer and head and neck cancer. So it's a meeting of specialists regarding a specific topic. For us and for what we're talking about is going to be a brain tumor board. So it's a meeting of those physicians that are involved in the specialty management of brain tumor care. And the purpose is to go over and discuss cases using a multidisciplinary approach. That means that we're all discussing it from each point of view, and then with the goal coming to bring a consensus on the diagnosis and the treatment plan. So you've heard that putting two heads is better than one, and that's essentially what a tumor board is. It's multiple doctors coming together and providing their opinions. So who comes to tumor board? Well, at our tumor board, we can have anywhere from 10 to 20 physicians and attendees. We have specialists from every area of brain tumor care. So we have neurosurgeons, we have the specialty radiologists who deal just with the brain, neuroradiologists, the neuro-oncologists, radiation oncologists. The pathologists come, and that's very important, to go over the pathology slides from surgery. Clinical trial specialists are extremely important to go over each case and discuss the possible clinical trials. We work with our ENT colleagues in the skull-based world, such as pituitary tumors and acoustic tumors, and they're certainly there. And the endocrinologists also come, again, for the pituitary tumors. And then tumor board is not just about patient care, it's also a very educational experience. And so there are students and trainees who are also there. So it's a pretty big meeting. Again, most centers, most institutions have their own tumor board. Here in Cincinnati, at the University of Cincinnati, we meet weekly, and I think most tumor boards probably meet weekly. We meet weekly for about 90 minutes. We review anywhere from 10 to 20 cases per week. So if you do the math, that's about 5 minutes a case. Certainly some cases take longer than others, and we provide the right amount of time for each case. We make sure for our tumor board that there's at least one physician from each specialty. So we want to make sure there's at least one neurosurgeon, one oncologist, one radiation oncologist, etc. But we really like for there to be multiple because we want discussion and we want multiple opinions to come to that decision. At our tumor board, as you'll see in the cases, we use a moderator. The moderator is there to direct the tumor board, to direct the discussion, to make sure we stay on track. Sometimes we do run off track discussing ideas and literature. Also to summarize the case at the end for the record and for the message that is going to be delivered to the patients and physicians. We also try to review based on clinical guidelines. So we use the NCCN, which is the National Comprehensive Cancer Network, which has published guidelines for many different types of cancer care. But for most tumor boards, we want to try to follow published guidelines whenever possible. So what is the goal of tumor board review? Well, the goal is different for each case. We definitely want to review the radiology, and sometimes that's really what we're doing is what is this lesion, what do we think it is, and what should we do about it? So we start by reviewing with the neuroradiologist, determine the diagnosis. Certainly for recurrent tumors, we want to determine is this recurrence or is this treatment effect? Of course, the treatment plan is extremely important. We want the surgeons and the radiation doctors and the oncologists to weigh in and give their opinions. What are the options for treatment, or is observation what we recommend? Pathology is important to review. Again, we review pathology slides to see so we can all see and share on the information from surgery, share on the tumor markers, and use that information to make our decisions. And we want to evaluate for clinical trials. Each case, whether there's a clinical trial available, would they qualify, are there multiple clinical trials, and discuss that as well. And then we also certainly present follow-up cases, cases after treatment, cases that we initially were following or observing, and what's happened over time. This is good not only for the patient care, but also for our own education and experience. So what happens after tumor board? Well, obviously, first and foremost is to get the information back to you, the patient. And so some of our tumor board reviews are done immediately before an appointment, and so right away we're going to meet with the patient after tumor board and go over our findings from tumor board and let them know. Sometimes we call the patient or family later that day and give them that information. We also want to let referring doctors and other doctors know. So with our tumor board, we provide a summary written statement through a database that then goes into the chart so that other doctors can see. But we'll also commonly call or directly talk to specific referring doctors. So if an oncologist sent me a patient to see, then I'll let them know right away what the tumor board review said, and that's important for everyone to see. How has tumor board changed? Well, the bottom line is that the digital advances, electronic advances, the things that make all of our lives easier now with computers and the digital era certainly helped tumor board. I can remember not too long ago, 10 years or so, it was gather all the x-rays, bring them to tumor board, try to get everything together. Nowadays, we can do everything online. So we can get the films online, we can share the films online. This helps a lot, especially for outside referrals. If someone from somewhere else wants us to view a case, then they simply have to download those files to our website, and then we can do that. So that increases efficiency. It also makes it easier for the radiologist to look at. So again, 5 minutes per case doesn't sound like a lot, but when we don't have to spend a lot of time putting up x-rays and films, then we can spend more time on the discussion. So that has helped a lot. We also use the information to put into a database. So we're storing that information so that the next time we do a tumor board review, we've got the information from the first review right at our hands. We can look at that, and we can use that for going forward. So all of these advances have helped out a lot. And I mentioned the database, and our tumor board does feed directly from a database. So again, we get as much information ahead of time. This is the kind of information that we would see in the tumor board, which would tell us, here's a patient, how old they are, what's their clinical history, she's got headaches for 5 months, and when was the MRI done, where's the lesion at, and what's the purpose of the tumor board discussion. So for this person, it's to look at the treatment options, any suggestions on treatment. For someone else, it might be diagnosis. And then this is the kind of area where we would then put in the information at the end for the tumor board review. So that's pretty much how our tumor board works on the database side end. So now I want to go through actually some specific cases for you, and we've got 3 cases to talk about, and I'm going to tell you about them ahead of time. So the first case is certainly the kind of case that we review every single week, which are patients with newly diagnosed glioblastoma, and several things that you'll see here. First of all is definitely radiology is very important. Most of our cases start with a radiology review, and certainly for glioblastoma, right away we get a lot of information from that. The surgical options are important, and you'll see that we talk about some different options there. Obviously for glioblastoma, it's very important to talk about the clinical trials. And the last thing is that although at the end of the day we want to develop a consensus agreement, we don't always agree, and that's okay. And so you'll see that there are some instances where there are different thoughts on what the treatment options are, and sometimes it is kind of a split, and at the end of the day we will share that with you. All right, so we're going to put this case on, and you'll see this in a second.
Dale, could you please present the next patient?
This is a 57-year-old white female who presents with a history of 5 months of headaches, and recently she has developed a left-sided visual field deficit, which prompted the current imaging.
Mary, could you please review the MRI scans?
We have a FLAIR and post-contrast T1-weighted images. On the FLAIR image, you can see a large area of abnormal signal in the right occipital parietal lobe with extension across midline. On the post-contrast T1 image, we can see a large irregular enhancing mass that corresponds with the signal abnormality. If you look at the central irregular areas of non-enhancement, that's indicative of necrosis of the tumor. Due to the overall appearance of the lesion, the signal characteristics, the location, the necrosis, this is most consistent with a high-grade CNS primary neoplasm, such as the glioblastoma multiforme. Other etiologies would be less typical, including metastatic disease, lymphoma. So again, most likely a GBM.
There are 2 main options for surgical options for treatment in this patient. One is a large operation to remove the tumor, and the other is stereotactic biopsy. On one hand, the tumor is very large and has swelling associated with it, so that would favor a larger operation. On the other hand, it's a very invasive tumor. It involves critical structures, and it crosses over to the opposite hemisphere. So as I look at this set of MRIs, I would favor stereotactic biopsy to establish a diagnosis for this patient, and then moving on with the appropriate therapy. Other opinions, surgical opinions, Dr. McPherson.
Yeah, I would probably fall on the other end of the spectrum. We have a lot of evidence that extensive resection certainly benefits. I think she could have a hard time with radiation given the amount of mass effect and swelling. I do agree this is a big tumor, and there certainly is a lot of risk from surgery, but she already has a visual field deficit, which would be the primary deficit I would expect. So I do think that we can achieve an extensive resection without too much risk to her, so I would recommend a craniotomy with an extensive resection. Maximal resection is what could be safely achieved.
Dr. Tu, what do you think about this patient?
Well, I don't think there's any wrong answer here. The patient always has a chance to hear what the experts say and weigh in their own opinion. You obviously are dealing with a very aggressive tumor in a 57-year-old individual, so there's some longevity. You want to get the very best you can for the patient, so I think I might come down on the side of offering the patient a radical operation, take out as much of the tumor as possible, which I think, based on our experience and literature, gives the patient the best long-run probability of quality of life. Obviously, you have to add to that other adjunctive therapies such as radiation, chemotherapy, but ultimately the patient will make the decision.
Dr. Pater, what's your opinion regarding radiation for this patient?
So for glioblastoma, the recommended radiation therapy would be 30 treatments of radiation to 60 gray of radiation. We would use IMRT or intensity modulated radiation therapy as well as image guidance to try to decrease the amount of normal tissue that's exposed to radiation. We would also get a fusion MRI after either the biopsy or the resection to try to better determine the area that needs to be treated with radiation. Using those different techniques specific to the resection question, I don't think there's a significant difference in the normal tissue that would be exposed, or certainly not in the planned schedule of radiation based on the biopsy versus resection.
And when would you typically start radiation after either of those scenarios?
So we typically wait a couple of weeks, but the main determinant there is the surgeon's opinion about how well the patient is healed from the surgery. And so if there are any complications or anything like that, we would certainly take the neurosurgeon's opinion into account for when to start. Additionally, there can be trials or protocols that would determine more specifically when we should start the radiation.
Dr. Riggs, what clinical trial would this patient qualify for?
So here the standard option after surgery would be chemoradiation, so the combination of radiation and chemotherapy with Temodar given at the same time for 7 weeks, followed by maintenance Temodar for a year. And I think that's a standard recommendation we can make the patient. But also this young patient is a candidate for a clinical trial. We have here the RTOG trial, which compares, chemoradiation versus chemoradiation plus sideronib. Sideronib is an anti-vascular agent. And these are two good options we can discuss with the patient in the multidisciplinary clinic on Wednesday. And I think, again, the patient is eligible for the clinical trial. So I would even favor the clinical trial if the patient agrees with that.
Any other opinions? Dr. Kindler, what biomarkers would you normally perform in order to gain information regarding clinical trials?
We have a number of molecular markers that we can utilize, both for prognosis, and then we have markers useful for research study. The molecular markers for prognosis include molecular studies for MGMT, 1p19q translocation, immunostains for IDH1, and then we also have EGFR V3 molecular studies, which are useful for clinical study.
Any other opinions? So the official recommendation of Tumor Board is surgery. There seems to be an opinion that the large operation is favored based on the size of the tumor, and then followed by either standard treatment with radiation and Temodar, or consideration for a clinical trial. We'll have the clinical trials nurse meet with the patient to discuss that. The case has been reviewed in accordance with the NCCN guidelines, and we're in conformance.
Okay, so the next case is a benign tumor, and certainly we spend a lot of time in Tumor Board talking about gliomas and glioblastoma, but we spend probably as much time talking about the benign tumors, the pituitary tumors, the acoustic tumors, meningiomas, and we even spend a lot of time talking about things that we don't necessarily know whether they're tumors or not. Sometimes lesions, spots on MRIs that we're not sure of, we'll review at our Tumor Board too. So this is a case of a pituitary tumor, and certainly for this one you'll see the importance of the radiology review, especially for these lesions when we're not exactly sure what they are, and then a focus on the treatment options of surgery and radiation.
Dr. McPherson, would you like to present the patient?
I would. This is a 41-year-old white female who was initially diagnosed 6 years ago with pituitary microadenoma. She failed a vision test with her ophthalmologist and got an MRI that showed the tumor. She saw a neurologist who recommended observation. She then had an MRI last year which showed some growth, but again, further observation was recommended. She then presented to my office this year with another MRI with some more change. Her visual fields have been recently checked, are intact. She's had all of the endocrine lab work, and all of that is normal.
Dr. Gaskell, could you please review the MRI scans?
We have 3 MR scans on this woman. This is her most recent one, which shows a lesion in the left sella. We can see it best on the post-contrast T1 weighted coronal images. On this study, it currently measures 1.3 centimeters in transverse dimensions. If we compare that to the scan done in 2005, it measured 0.7 centimeters, and then on the scan from 2010, it measured, increased to 1.1, and again on the current study, it measures 1.3 centimeters. So gradual increase over the 3 scans, and it is consistent with a pituitary adenoma.
And how close to the optic nerves is the tumor?
There's actually very mild suprasellar extension. The point where it's closest to the left prechiasmatic optic nerve is about 2 to 3 millimeters. There's no cavernous sinus involvement.
Well, in terms of treatment option, Dr. Tu, what do you think about this patient?
Well, I think this patient actually is best suited for surgical treatment, but you could consider radiation, but she's young. You've followed her for a period of 5 years. It's doubled in size. The tumor is still confined to the pituitary area. It's not causing suprasellar compression of the optic apparatus. So it's an elective procedure, but given the increased enlargement and the ability of surgery to cure this tumor, I think that would be the best approach. The technique would also offer a very low morbidity, and that's the technique where you actually go through the nose, so there's no incision on the skin, has very low morbidity, and a low probability of causing pituitary decline or pituitary insufficiency, because the patient still has, as I understand, a normal functioning pituitary gland, although it's compressed increasingly by the tumor. So I would recommend that approach and to the patient, but I'm sure that there are those who may want to consider radiation.
Dr. Brenner, what are the radiation options for this patient?
Yes, well, I do agree that treatment is indicated in this instance with the progression seen on the serial scans. There are a couple of radiation options. There would be the choice of using a fractionated radiotherapy regimen that would be daily treatment 5 days a week over 5.5 weeks. But because this tumor is far enough away from the optic pathway, I think that radiosurgery, a single fraction treatment, is also an option as well. And that has the advantages, of course, of being done in a much more compressed fashion with much less difficulty for the patient in terms of back and forth treatment. Both of those options do give pretty good tumor control. I think, though, in a young patient where there's a lifespan ahead of them of many decades, there's just not as much data about radiotherapy being effective 30, 40 years after treatment as we have with surgery. And for that reason, I would favor surgery as well. I agree with Dr. Tu.
If the patient wished to pursue radiation, which of those would you choose for them, and what would be the risks in terms of hormonal dysfunction?
The radiosurgery would be a good option because it is that single treatment. Now, the hormonal dysfunction after radiosurgery is probably going to be a higher risk than it is with surgical excision. It would, over the period of the following 5 or 10 years, run about 30%, about a third of people.
Dr. Pater, what's your opinion regarding radiation for this patient?
Again, I think given the relative lack of long-term data going out 30 to 40 years for radiation, I think surgery would be preferable. I think if the patient did want radiation and wanted to avoid surgery for whatever reason, the stereotactic treatment would be the preferred method, again, because of the distance between the critical structures being sufficient for that treatment.
And can one of the two radiation oncologists here address the potential need for radiation after surgery?
If this is a complete resection, then there would be no indication for radiation. If there was some concern that there was residual tumor afterwards, then I think depending upon what the degree of concern was, you could either observe for a period of time or consider radiosurgery to the remnant at that point.
Dr. McPherson, after hearing all of these recommendations, what is your final recommendation to the patient?
I agree with Dr. Tu that given her young age and
progression over time, that surgery with the endoscopic approach would be my recommendation, but obviously radiation would be an option to discuss with her. So our official tumor board consensus is surgery is the primary option. Radiosurgery is certainly another option available to the patient, and there are no NCCN guidelines that pertain to pituitary tumors. We'll communicate this to the patient and to the referring physician.
Okay, so our last case is certainly something that takes up a lot of time, importantly, in Tumor Board, and that is a discussion of recurrent tumors. As you'll see in this case, certainly, again, radiology is very important. Determining recurrence versus treatment effect, especially in recurrent tumors, is a difficult thing, and certainly something that radiologists help out a lot with. Obviously, treatment options, but especially for the recurrent tumors, a big part here is clinical trials. So we'll present this case.
Shannon, could you please present the patient?
Our next patient is a 58-year-old white male, initially diagnosed with a glioblastoma after having had 2 seizures. He underwent surgery a year ago, followed by radiation and chemotherapy with Timidar. Over the last few months, has had increasing headaches, increasing difficulty with speech, getting his words out, and incoordination of his right hand.
Mary, could you please review the MRI scans?
Displayed, we have 2 MRs about 4 to 5 months apart. On the first scan, on the post-contrast T1 weighted axial images, you'll notice that there is no abnormal enhancement in the brain parenchyma. We do see some post-operative changes. On the scan done about 4 to 5 months later, we see a large irregular area of enhancement in the left frontal lobe. And this appearance is very concerning for recurrent tumor. We actually did metabolic imaging on this patient, including spectroscopy and perfusion. Both of those showed that this area of an abnormal enhancement is most consistent with recurrent high-grade tumor.
Is there a role for additional surgery? Dr. McPherson. I do believe so. It's in the left frontal lobe, the dominant hemisphere, but I believe that surgery is safe. I would recommend surgery, but I would get a functional MRI ahead of time for planning to map out his speech area and the motor area. But based on what I'm seeing here, I do think surgery would be my first recommendation. Since this is a recurrent tumor, I would recommend placement of I-125 seeds, radiation seeds, and the chemotherapy wafers would be a good option for him. Is there any role for one or the other of those treatments, the seeds, wafers alone? Why would you use them together in this patient? Well, we have good evidence, especially out of our institution, that combining the two has a somewhat synergistic effect, that there's more benefit from having the two together than just one alone. There are some individual situations where one we might not want to use versus the other, but I think for him, we could combine both and give the best potential effect. Dr. Tu, what do you think about this patient?
There's 2 ways to look at these things. You've got a patient who's had aggressive surgery. Doing it again may add some lifetime, but does it add quality of life? Does it add something that the patient really desires and benefits from? I think we have to present that to them in a very clear way that they can understand and let the patient make a choice.
Dr. Brenner, what are the radiation options for this patient?
As Dr. McPherson said, I think that after surgery or together with the surgery, using an implant with an I-125 radioactive isotope would offer the potential for giving additional radiation to the area where the tumor has recurred and being able to confine it to that area without unnecessarily exposing some of the surrounding tissues that had previously had radiation in this case. That is going to help, I think, in local control of this, and it's going to minimize the risks of further injury from treatment due to the radiation. And as Dr. McPherson said, the addition of the chemotherapy wafers, I think, also is a good idea.
Is there ever a role for repeat radiation after the previous radiation?
If this was a case where surgical resection was not possible, then we could use a radiosurgical technique to also use a more confined dose of radiation to that area of recurrence. And that's often combined. We would ask Dr. Ricks whether Avastin could be used in this case as well to help both potentiate the effects of that external stereotactic radiation and protect against any potential adverse effects with necrosis.
Dr. Chowdhury, what are the chemotherapy options for this patient?
As Dr. Brenneman mentioned, that Avastin is a wonderful choice at this point. Avastin is what we like to call a targeted agent, so it really targets the blood vessels of the tumor and works differently than temozolomide or other chemotherapy agents that we have. And after Avastin, we have some potential open trials that should be coming in, and I think Dr. Ricks can speak more to that.
Dr. Ricks, what clinical trial would this patient qualify for?
So when we get the result from the biomarker studies, we can see the patient is a candidate for a phase 1-2 study with an anti-EGFR variant 3. So this is a target expressed in 30% of these patients. And we have a very specific drug now in development here at UC for this kind of tumors. So this anti-EGFR variant 3 could be one option. And the other concept we develop here is a dual inhibition with two very specific molecular targeted agents targeting PI3 kinase and mTOR, but could be also another option. So all these options can be discussed with the patients in the multidisciplinary clinic based on the biomarker studies, based on the tissue analysis. So I would really favor surgery first and then move to those standard options or clinical trials.
Well, speaking of biomarkers, Dr. Kendler, how long would it normally take to get those biomarkers and thus be able to know if the patient is a candidate for this clinical trial?
Usually we have results within a week or so, sometimes a week and a half, and we can deliver those results to Dr. Riggs.
So around the time of the postoperative appointment in the multidisciplinary clinic, you would have your answer. So the official tumor board recommendation is, on one hand, one option would be surgery with implant of I-125 seeds and gliadel wafers. The other option would be repeat radiation, probably 5-fraction radiosurgery in conjunction with Avastin. And third, consideration of a clinical trial based on the biomarkers. We reviewed this patient in conjunction with the NCCN guidelines and were in conformance.
Okay, so hopefully with those three cases, you see now how Tumor Board works. The bottom line is Tumor Board is a group opinion. It's multiple specialists coming together to provide an opinion, hopefully opinion that we all agree on. Sometimes we don't, but hopefully we do, and provide that opinion to direct diagnosis and treatment. The ultimate goal, obviously, is to make a plan for the whole team to help deliver to you, the patient. Clinical trials are extremely important. We review every case for clinical trials, and you saw that too. And I think you also understand now the importance of Tumor Board really from the team standpoint. This is one of the few times that all of us get together in one place, talk about our cases, and we learn a lot from that, and also helps us to work as a team and to work to help you. So that now concludes the presentation, and I will turn it over for any questions.
Thank you, Dr. McPherson. We will take questions. If you have any questions you would like to ask, please type and submit it using the question box in the webinar control panel on the right-hand side of the screen. I do have some questions that have already been asked, so we will start with those. Dr. McPherson, how do you get your case in front of a tumor board?
So sometimes it's the physicians who direct that. So I may personally choose to present specific cases. Certainly we have patients that request, and we have both inside and outside patients. So you can always ask your physician as a patient that, gee, I'd really like this case presented at Tumor Board, and we would do that. And then we also, nowadays through online, we get a lot of outside referrals, as I know most centers do. And so people from other places will certainly sometimes submit their cases. Maybe they're just looking for confirmation of treatment that's going on somewhere else, and it saves them from having to travel far just to get that opinion. And we're happy to do that, just as I know many other centers do that too. So the online way nowadays is a big way that a lot of people are doing that, because they can submit their films and their information online to us or to another center, and then we can present that and then get back to that patient and let them know if there's anything that we could offer, maybe a clinical trial or something that would then be worth traveling rather than just travel to find out that it's the same treatment plan.
Thank you. Another question that we have is, do the neurosurgeons ever opt away from surgery?
Definitely, yeah. And as you saw in the first case, again, there was a disagreement there as whether it was a biopsy or a major surgery. And there are times that we as surgeons say, absolutely not. First thing that I'll say on this case is that no surgery is an option. Either maybe it's unsafe, we fear causing a neurologic deficit, maybe it's someone who's already had surgery, or maybe it's something that we think is better treated with radiation. So definitely that is, it seems sort of like the surgeons always say surgery and the radiation oncologists always say radiation and the oncologists always say chemotherapy, but that's not always the case. So we do definitely try to look at it from a balanced standpoint and provide the appropriate recommendations based on that.
Thank you. And we have a follow-up to go along with that question. If the tumor board cannot come to a consensus agreement, how do you tell the patient that, and do you give them options?
So that is important, and I always communicate that to the patient. I'll tell them that there was not agreement at Tumor Board, that maybe there were 3 neurosurgeons and 1 said that he wouldn't operate and 2 said that they would. And then exactly that, it's unfortunately then kind of falls back on the patient to decide, and say, well, this is sort of the thought process of those different neurosurgeons, and then ultimately the patient has to make the decision. So we try to come to a consensus when we can, but obviously medicine is an art and not a science, and it's not always 100% knowing exactly that that's the right answer.
Thank you. Another question we have, do patients or caregivers ever participate in the tumor board?
So we don't typically have patients or caregivers at the tumor board specifically. I think it's good to have a bit of a neutral viewpoint, everybody to talk about the case without actually having the patient there. In addition, we do discuss multiple cases, and certainly nowadays with the HIPAA rules and protection, we can't really have patients there because of the other patients being discussed. So we haven't done that. I don't know about other centers who may have done that. We always do it as a closed meeting, and then we bring that information back to the patient.
Thank you. And another great question from the crowd, does every hospital have a tumor board?
So pretty much every hospital has some form of a tumor board. Some of the more community-based hospitals may have one tumor board for all tumors. The larger centers, the specialty centers, will certainly have more specialty tumor boards, as I mentioned, like a lung tumor board or the brain tumor board. I would say most of the major cities and certainly the major brain tumor centers are going to have a brain tumor board.
Thank you. Another question from the crowd. Besides the doctors, are there other types of healthcare professionals that participate and give their opinion?
So there are, obviously, as you saw, the doctors sort of dominate. We have a tendency to do that. But the nurse professionals, the nurse clinicians are definitely there. They serve more to provide information. So we might ask, well, for an acoustic neuroma, do we have the information on their hearing? And they may be able to get that information for us. Certainly with the clinical trial specialists are there, and sometimes we ask them about, well, would this patient qualify for this clinical trial based on our current information? There's a lot of other support personnel, administrative personnel that are there. They don't always directly involve themselves at the tumor board. So we're certainly open to input from everyone. Again, residents are often there, and if they have input from having seen the patient, they certainly speak up as well. So we try to get as much input as we can.
Great. And what happens when the patient does not agree with the tumor board suggestions?
Well, that's an important question. You know, sometimes, you know, just like every medical opinion, it's just that it's an opinion, and you know, our tumor board is the opinion of 10 to 20 physicians, but maybe that's not exactly what the patient agrees on or what they want to do. And so, you know, there's two different avenues there. Certainly, it's obviously always open to a discussion with the patient. You know, again, that may have been that we recommended surgery, but the patient wants radiosurgery, and if we think that's a reasonable alternative, then we're going to go along with that. If it's something that, again, doesn't fit with our recommendation, then it may be there's always other opinions at other institutions. So, you know, again, the tumor board is an opinion. It's a group opinion for multiple people, but it's not always the final word.
Thank you so much. That looks like it concludes the questions that we have had from the crowd. So at this time, we will thank you all for joining us, and thank you again, Dr. McPherson, for your knowledge and your time. For more information on the topics discussed here today, or for more information on brain tumors and their treatment options, our licensed healthcare professionals can provide you with support or help you navigate information available on our website. So call the ABTA care line at 800-886-2282. Let's pause a moment just to conclude the webinar recording.